Welcome everyone to today's webinar, 5 Ways to Keep Your CIN's Top Performers Happy. I'm Kelly Gooch with Becker's Hospital Review. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'll walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If at any time you don't see your slides moving or have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box and we're happy to help. With that, I am pleased to now welcome today's speakers, Lynn Barr, founder of Caravan Health and Chief Innovation Officer of Signify Health, Dr. Manjula Jolka, Vice President of Medical Affairs, Senior Population Health Officer with Signify Health, and Sean Rhodes, Regional Vice President of Caravan Health, which is part of Signify Health, and former Director of Clinical Integration. Before we get started, we have our presenters tell us a little bit more about yourselves and your background.
Thanks, Kelly. This is Lynn Barr talking. I'm founder of Caravan Health, and I'm very excited to be the Chief Growth Officer or Chief Innovation Officer at Signify Health. I am joined today by Dr. Manjula Jolka, and I'd like for her to introduce herself, please.
So hi, everyone. I'm the Population Health Officer at Signify, a board-certified family doctor, still practicing part-time. Have been in community private practice as a hospitalist in large urban academia setting, and steered over $75 million in shared savings over 3 years as the first medical director of when CIN came about, and somewhere along the way fell in love with data and possibility it brings to improve population health.
Thank you, Dr. Jolka, and I'm also joined by Sean Rhodes. Sean?
Thank you, Lynn. I'm Sean Rhodes. I'm Regional Vice President with Caravan Health, overseeing the Southeast region of the United States and some proprietary ACOs within Caravan. My career has been about 20 years in healthcare, focusing on performance improvement, quality improvement, organizational development, and value-based care, really looking to make an overall difference in how do we make healthcare more affordable and more efficient and more effective for those that we serve.
Thanks,
Thank
Sean.
you all.
Go ahead, Kelly.
Yeah, thank you for being here. And I'll now turn the floor over to the team, the Signify Health team, for the presentation itself.
Thank you. Thank you very much. Hi, this is Lynn Barr, the founder of Caravan Health. I'm really excited to talk to you today about things that we've learned about helping CINs keep their CINs together and really dealing with the heterogeneity of all the practices that we're trying to work with at once and all get rowing in the same direction. So hopefully you'll find this meeting today interesting and informative and hopefully somewhat entertaining. I did want to let you know a little bit about Caravan and Signify. So Caravan Health started in 2014 as an accountable care organization. We have saved Medicare almost $500 million to date and earned more than over $235 million in shared savings on behalf of our clients. We have participants all over the country, and we're joined by, and we were very, very fortunate to be acquired by Signify Health in March of this year. So together with Signify Health, which is the #1 leader in bundled payments, post-acute care, in-home evaluations, HCC coding, they bring tons of expertise to the table. Caravan's been incredibly successful in managing population health and putting ACOs and providers together. We have more than 200 provider organizations in our ACOs today, and between Signify and Caravan, over $10 billion in spend under management in our programs. The #1 value-based network, and it's built on this chassis of 6 collaborative ACOs across the country. I look forward to telling you more about Caravan Health someday, but I really want to get into our presentation and start from there. So let's talk about the problem a little bit. The problem is that we're working with communities that are trying to coordinate care around their patients and are forming clinically integrated networks. And the problem is that not everybody in the network is the same. So you have very high performers that have been doing this work for decades, right? And they are ready to move on to the very next thing, and they want to participate in all the leading edge programs. And you have from there, you have all the way down to people that are just very cautious and concerned about these programs. They may have tougher economics in their practice or tougher patients, and they don't, or they may be small and independent and concerned about the ideas about taking risk. So how do you, and you know, and I hate to classify these as high performers and low performers, because honestly, that's not really what we think about the physicians that are practicing out there. What we think about are practices that are not geared up to do prevention, wellness, and chronic care management, and that have not really advanced their practice beyond fee-for-service. And so somehow we have to figure out how to make it work for everybody. And the problem is that if we don't, people will come pick off the high performers. They have more to bring to the table for these value-based arrangements. And if we lose all of our high performers, then we're going to become less attractive as a network and less able to move the entire network up. So now how do we figure out how to work together with both high performers and low performers in a single organization and make it work for everybody? And I just wanted to turn to Dr. Jolka and to Sean, both of them with tons of experience in clinically integrated networks. If you guys could give us some color on what you've seen in your experience. Dr. Jolka?
Yeah, sure. You know, I want to share, I remember hosting a combined town hall to celebrate significant jump in our shared savings. This was year 2 years in a row, and I said, okay, we'll have a bigger gathering and we'll slide in how to finish third year strong. Planned a big gathering, community, university practice mix, food and wine was flowing, all good. But when we got to the part of sharing performance report, emotions in the room changed. There was some awkward verbal expression of anger and frustration, as you know, for people who were performing well and felt they were contributing to the success, and looking at folks that were holding the performance to be even better. And of course, there were some more eloquent texts and calls that followed. But as I looked around, to your point, Lynn, the room was filled with a spectrum of different risk appetite, resources, value culture, and even the way fun trickled, you know, methodology was different. Lots of learning for one night for sure.
Sean? Thanks. Sean, how about you?
Very similar experience. You know, emotions run high when you start looking at performance and results overall. People always want to gravitate toward what's bad instead of trying to really leverage what's good. So you get in those meetings, and Dr. Jolka's right. There's some yelling going on. There's some very specific discussions that are happening outside the room that becomes obvious. And so trying to figure out a way to how do we get all of those together to really avoid those situations, but really make sure we're paying attention to those that are high performers and how are they doing, and how do we teach the low performers? You know, is it understanding? Is it education? Is it ability, resources? There's a variety of different things, and I think we'll talk more about those as we go through today.
Great. Yeah, we are definitely going to be presenting some solutions to this problem as we move forward. Thank you. As we think about the value-based trajectory, we're starting a fee-for-service. A lot of our providers are involved in bundled payments and are really engaging with their specialists. We have total cost of care models and full risk. And so what we're starting to think about is if our goal is to keep the network strong, I think what we have to do is find a value-based program for every different participant. And so everybody belongs in a different place. And so trying to find one size that fits all isn't working out there, and we're watching networks break apart. So what Caravan and Signify have been doing is coming out there and trying to bring these together so that we can meet every practice where there are, but still have one program for the entire CIN. So let's talk about the 5 ways that we think it's important to keep your CIN aligned. One of them is you really have to know your practices. You've got to be able to classify them so that you can assess their readiness and group them so that you can put them in the right programs together. So if you group novices with very high performers, the high performers, to everyone else's point, are get upset about that, and the novices feel like the programs that people are talking about aren't appropriate to them. So we've got to group them in the right groups and not try to combine them all into the same value-based programs. We need to identify and share goals and local opportunities, provide tools, training, and support for success, identify and manage that out-of-network spend. So one way you can really help keep your CIN together is help manage the stuff that they're not managing today, which, in our experience, across our 600,000 lives that we have in ACOs today, 65% of the care is delivered by TINs that are not in the ACO. So we have to help them manage that so that we bring all boats up, and then we need to incentivize appropriately. So getting into assessing readiness and grouping peers, we need to really start thinking about performance. And I want to turn to Sean, because as a regional vice president for the Central East Coast, he does this every day with the practices he works with under Caravan. Sean, can you tell us a little bit about what you do?
Absolutely. So, our role in really working with practices is trying to meet with practices where they are. We often say that if you've seen one practice, you've seen one practice. And so trying to understand those differences, and as Lynn spoke to, group those like ones together and really facilitate that. One of the key things we do with that is data. Deming once said, if you don't have data, you're just another person with an opinion. So we really like to look at actionable data to drive our decision base, understanding where the practice is with their ability to use data, assessing their readiness, looking at how they're structured, looking at what networks they work with, what technology and analytics they have pulled together, what transformational efforts, how do the workflows and processes work within the practice? Are they involved in different payment models in any way, shape, or form? And how engaged are the physicians and providers in that practice to do that? One thing we have to continually focus on is education. There's so much changing and so much changing rapidly. How do we make sure that we understand and provide that education to one another to do that? In transparency, there's a lot of transparency, a lot of talk of transparency, and I think a lot of times that transparency leans more towards looking and identifying opportunities, which is definitely a focus. But our primary focus when looking at a network and looking at a group of physicians is to leverage the strengths. Everybody's at different levels. How do we learn from those strengths, and how do we leverage those strengths? Don't focus on the opportunities first. Focus on the strengths, because if you do that, those opportunities will align well with the strength that you have in those networks in trying to bring those together.
That's great, Sean. Thank you so much. One of the things we think a lot about at Caravan is data, as Sean said, and at Signify as well. And so as I'm looking at our performance, and one of the things back in 2018, we were running 38 ACOs simultaneously that all had between 5,000 and 20,000 lives. And we saw tremendous variability in their results from quarter to quarter and year to year. There'd be winners and losers. And so one of the things that we started, and we had a hard time interpreting data. I would look at a practice and go, what do I think about this practice in terms of cost related to the community? And there's so much information I don't have. And then the other side of it is that the data is so variable that you can't interpret it. So it's very important when you're dealing with your CIN, understand what you can and cannot measure, and understand that in almost most cases, you cannot measure cost and quality at a practice level, or even less so at a provider level. So you are going to have to look at a lot of different things, as Sean was talking about in his assessment, and do not judge practices by cost and quality without having a much larger picture, and do not judge anyone by a single data point, because the variability is very high. And this creates a lot of frustration, because our physicians believe data needs to be right. And if, you've got a 5,000 life ACO and you have savings or losses, the 95% confidence interval on that savings or loss is plus or minus 6%. So you might have a loss or you might have a savings. And so we have to really understand the context of the data that we look at. So we try to, when we're trying, one of the key things that we look at practices and try to understand where they are in terms of other practices, particularly in their county and in their region, we look at data longitudinally. And because there's a lot of movement going on, and as you know, one physician can leave a practice and everything changes. So we need to look at things longitudinally. So I'm showing you this slide here, and these are 4 different practices where I have their longitudinal data on the screen. And in the first one, I'm going to look at attribution, all person years, and how that might have changed over time. I'm also, a very, very important number for us to understand as we're classifying our practices is the regional efficiency number. Regional efficiency is the cost, average cost per patient in the practice versus the average cost divided by the average cost per patient in the county, risk adjusted. And this gives us a sense, this is kind of the best sort of, particularly over time, of how this practice is going to be perceived in most value-based arrangements. So scores below 1 are typically perceived very highly in those arrangements and can generally earn the most. And scores above 1 may even suffer penalties in value-based arrangements because they're considered more expensive than their peers. And so they also need to be grouped together so that those penalties aren't assessed against the high-cost providers. So then, of course, we'll look at expenditures, but the most important thing also to look at is HCC. So what does this population look like? And, I think it will surprise no one to find out that lower HCCs are generally associated with more regional efficiency. So as we look at that, and we want to make sure, are those HCC scores increasing over time? Are they decreasing? Are they staying about the same? What is the activity of the practice in coding? Because if you don't do a good job in coding, you're not going to be successful in the program. So look at data, at data in comparison to your county, and look at HCC data and look at data over time to try to as one of the ways to start putting your providers into different buckets. And then what we do is we take all of the work that Sean does, the assessments, et cetera, we take the data and the longitudinal data, and then we classify people into different programs. And so somebody asked me, give me an example of a program that would incentivize high performers while helping to improve low performers. What Caravan and Signify have done is we've taken our ACOs, and we have such scale, we have 600,000 Medicare beneficiaries. So our clients all fall into one of those 4 buckets. They're either, they're just getting started and they haven't fully adopted the basic programs that are critical for success, and in which case we put them in a basic ACO, and we expect them to earn about $100 to $200 per patient per year. Once they have mastered the programs, we can put them into an intermediate ACO, which is typically, we can put them into an enhanced ACO, and based on their regional efficiency, they will either be in a high-cost enhanced or low-cost enhanced. And this way, we make sure that everyone gets the payment that's most appropriate for them, and we use this as a way of peer grouping. And so if you are in intermediate enhanced, or if you're in the enhanced ACO, but you're above the regional benchmark, we would expect you to earn $300 to $500 PPPY if you're following our program. If you have been doing this over time and that practice has excelled, and you can see that in the regional benchmark, then you can put them in the low-cost enhanced. This ACO will earn more than a high-cost enhanced ACO, and we would expect about $500 to $700 PPPY. And then for your really, really advanced practices that are chomping at the bit to experiment and to get out of fee-for-service completely, we can offer them a capitation program which is where what we call our expert program, which is the new CMMI REACH model. And in that program, if you have qualified for that program and you're amongst the elite, we would expect them to earn about $800 to $1,000 per patient per year. So this is how we keep everyone happy. We group them with people that are like them. We're working on programs that are appropriate for each level of development for them. And everyone's getting paid what they deserve based on their time and experience and engagement in the program. So I'm going to turn this over to then to Sean again to talk about how we go about identifying shared goals and local opportunities. Sean?
Yeah, thank you, Lynn. So when you think about shared goals and opportunities, you have to look at it from the standpoint that communication is going to be key. Collaboration and communication, you have to make a continual focus and an effort for that to be upfront. When you think about goals and setting those goals and those targets, as Lynn said earlier, you can't pick one measure and judge a practice or a provider on one measure. You've got to take the financial pieces of it as well as the clinical pieces of it and bring those into the conversation to understand those together. You really have to establish that mindset with the group. It takes a lot of education and a lot of understanding. These programs can be complex. You have to take time to sit down and understand those programs and be sure that they understand, when we're trying to reduce utilization, we're trying to keep people healthier and happier at home. How do we reduce that? So that's not really a loss of revenue. It's more of reducing the cost and bringing more value to the overall program that you're in. And when we talk about local opportunities, how do you collaborate with those in your local areas? Providers on the post-acute care side, the inpatient side, having that collaboration and that teamwork will develop better relationships, but they'll also really show opportunities between where do you struggle, where do they struggle, and how do our missions come up to align with one another. And developing that strategy where you not only engage physicians, but you engage practice management. So the practice managers, the nurses in the practice, they all need to be involved in some way, shape, or form to really work with those, because they're all working collaboratively as a team with those patients that are across the care continuum. The next slide. So one of the things that we really focus on, as I said earlier, is leveraging strengths. And when you look at an organization and we identify and we grab data from an organization, we have a large database, 600,000 lives that we look at overall in our ACOs. We're able to really make a comparison on the patient level. So patients, apples to apples comparison. Our patients are like this. So how are others handling those patients from a utilization and a cost standpoint? And we use this type of data here, and you can see in the Christmas tree ornament, for lack of a better term, on the graph, the blue dot indicating where a particular provider or practice is. Where are there opportunities? When you look at those, you can then leverage those and look at the strengths that you have not only in your own network, but across the healthcare continuum. Healthcare is really my second career. I started out in engineering background, and I started out working in automotive with Toyota and Honda. In moving to healthcare, one of the biggest things that was a drive, but besides that healthcare was a little behind in the times related to technology, was the amount of sharing that went on from organization to organization. Every ACO we work with, every practice we work with is always willing to share their best practices, how they dealt with the problem, how they addressed an issue, how they leveraged that particular strength. That is a great asset that we have in healthcare. And anytime you see a problem or an opportunity, there's always somebody out there that has already had that problem and opportunity. So we do a lot to create that collaboration across our network to really help people learn from one another and provide guidance with one another overall. Next slide, if you would. So talking about
thank you so much, Sean. Oh, I apologize. So thank you. And I wanted to then introduce Dr. Julka to talk about how we provide tools to improve success and how important that is to achieving overall performance in your CIN.
Yeah. So as Sean described, it's important to have a trusted data. It's important to have it in a meaningful, actionable visual. So I know actionable data is an overused term, but that is truly key to success. Because the way I see it, it tells you what to do and how to do. So the first question is, where are the opportunities lying locally? That's the first thing. And second, based on your strength, where can you intervene? And the third is, which of the interventions will actually move the needle to see an impact this year itself, and what can be planned for the success that would showcase in next year and be more sustainable. So that's getting what sorted at the local level. And now let's talk about the how part. Everyone has staffing and resource challenges. So it's very critical to stratify and identify the populations or workflows at the intersection of clinical and financial opportunities. So being smart and focused about it. Engage your providers early on, and even the interdisciplinary influencers locally. If you build tailored value propositions, have clear achievable goals, and design support, they can really be scrappy and innovative. I have seen great, quick testing pilots and then turning into the workflows and sharing, as Sean said, in collaborative ways with others, because what you are facing today, someone else faced before, and someone will face again. So bringing that collaboration. And again, do not forget to measure what you can on a regular basis for directionality check and pivot if needed. Next slide. It showcases that there are several things in the clinical toolbox for both high performers and low performers for their next opportunity for additional improvement. Share the landscape of leakage, of wastage, of preventable ED visits, of rehospitalizations that could have been avoided. Point specific opportunity in quality in the post-acute network, the high-cost myths, and coding. Slice and dice data differently for visuals that are digestible for different users, whether it's your CFO or your primary care provider or your case management based on the desired action that's needed. The next slide is actually an example of relevant data, which is presented in the form of a face sheet just before an office visit in a busy primary care clinic. So for high adoption, it's very important to have a seamless integration into existing workflows. This provides very easy, quick view on coding opportunities for me as a family doctor, on quality and health maintenance gap closures, very valuable sneak peek at patients' utilization between my last visit with me and now. Patients has been to EDs, hospitalization specialty networks, in network or out of network. Many times you ask primary care physicians, in my regular monthly meetings, I have no clue what's going on with my patients in between last visits and now. And you are telling me all this out-of-network cost is attributed to me, and great. So this is a great opportunity that provides them with ideas how we can coach our patients or optimize care coordination to make sure that primary care physicians are kept in the loop. It even shows a lot of information, much more than their risk profile and even the medication adherence. A lot of opportunity where one can act as a primary care provider.
Thank you, Dr. Joka. Awesome. So next, the very, very important is to ensure transparency and accountability. So when Caravan realized that we had, like I said, 38 ACOs that were bouncing all over the place, we all looked at each other and said, well, how are we going to take risk when we have so much variability in spend? And so we decided to bring our clients together in ACOs that have at least 100,000 lives in them. And it seems so obvious now. At the time, everybody was shocked, but if you look at it, this is what ACOs are really a form of insurance company, and it's a managed care plan, right? And insurance companies don't start plans on 5,000 lives. You need to have a lot more scale than that to really be able to see your results. So, if your savings or losses are 3-4%, you better have, at least 50,000 lives to be able to see that kind of improvement and to protect yourself from downside risks. So we primarily work with safety net hospitals and health systems across the country, and they have no appetite for taking risks. So we started putting all of our clients together, and we might have, 20, 30, maybe even 50 rural health systems in a single ACO that are all sharing the savings of the collective group. Well, the problem with that is that this is a CIN problem. It's it's a problem we had to solve. You have to solve, is that you're going to have high performers and free riders, and the two are the high performers are not going to stick around. And so what you have to do is, in addition to everything else we've talked about, is you have to make sure you're holding every participant accountable. And so every single practice has to be monitored at a process level to make sure that they are still engaged in the program, because sooner or later something's going to happen and they're going to lose focus on your program. And when that happens, you won't know about it if you're waiting for the end of the year to see what their quality scores are that, in our point of view, you shouldn't be interpreting in the first place, right? Or you're looking at costs, but you don't really know if their costs are really higher or lower because the numbers are too small. So what Sean's going to talk about now is some of the tools that we've developed to keep participants in the loop and to keep their performance on track. Sean?
Lynn. So as a part of keeping them on the track and really focusing on that collaborative effort, we've talked a lot about actionable data and what does that mean. We've talked a lot about identifying opportunities for improvement. And looking at those things together, you have to really take into account, you can end up in a paradigm, if you're not watching these things collectively, that you're getting better and getting worse at the same time because everybody else is getting better faster. And so you have to maintain that constant look of looking at that data, understanding what is your overall spend, understanding your patient engagement, looking at leakage within your network. How are you doing on quality indicators and following those particular metrics? You have to look and leverage those strengths and opportunities that we talked about earlier and define those targeted initiatives. What are those key things clinically and financially that we are going to measure everyone by that we can then build a remediation plan upon? And that remediation plan, it sounds terrible, but it is a necessary thing to make sure that everybody pulls their own weight. I use the analogy sometimes, when you have that project in college or in school where you always had one person that was kind of lagging behind. Well, you have to identify those folks early. And our role and our goal is really keeping monitoring all those metrics and the data so that we can reach out and we can support that individual practice providers more heavily for a period of time. How do we help all ships rise together? And how do we focus in on what are their key things that are driving that? Is it resources? Is it process? Is it workflows? And how do we do that collectively to help them? And if that doesn't move the needle, a lot of times then we look at a 90-day performance improvement plan. What are these key issues? What do we need to address? And we need to get that done within about a 3-month time period. Most of the time, our practices, actually I would say all of the time, it's not the willingness, it's more so the ability. And ability comes with understanding, with putting the resources in place. And one of the things that CIN can leverage is that collective network to be able to help and support the practices collectively. That really helps pull everybody up at the same time and gives some additional resources to really help them with some expertise overall. Next slide, please.
Yeah, Sean, I just want to add a comment, Sean, that when Caravan first started, we didn't have a published metrics that every practice was supposed to meet. And again, and Sean will talk about these. These are these are leading indicators that you have to think about so you get the outcomes you want. And once we implemented the leading indicators program at Caravan, we went from about 20% of our practices losing focus on the program during the year, which is I think what most people experience, to less than 5% of the practices actually being excused from the program every year, which is probably what everyone needs. And so the other part of this message is, you can't judge people on cost and quality, but if they sign up to be part of your program, they have to do the work. And so you need a way to measure whether or not they're doing the work. And if they refuse to do the work, that's their choice. You can't just keep them, you know, as part of your value-based contracts, you know, to be nice. But remember, this has to be tied to things they can do, not achieve a quality score that may not even be possible because of the nature of their patients. So, Sean, would you explain a little bit about the leading indicators that we use at Caravan and Signify to help identify practices that need to go into remediation each year?
Absolutely. So we start by looking at outcome measures, which in these two examples here, you'll see on the left-hand side. And those outcome measures are what do we want to see happen overall within our value-based programs and the care for our patients. We want better outcomes. We want better quality. What are those things that look at to drive those outcomes? So inpatient readmissions per 1,000, ED rates, readmission rates, understanding our use of home health and post-acute care services. How are we maintaining those things? And we back up from that, and then we begin to look at process measures. What are those things that drive the outcomes? So when you look on the right-hand side, you see those process measures. Looking at SNF utilization, how many patients were sent to a 3 to 5 star? If you think about follow-up care and discharge planning related to readmission rates, are we doing transitional care management? How many patients do we have in chronic care management? And how many high-risk patients do we have in chronic care management? Are we identifying them appropriately, reaching out and building that relationship with them? Are providers being able to prescribe the right medications, but when you do the right medications, are those patients being able to fill those medications? So sometimes social determinants of health come into play. So looking at refill rates and understanding, are they utilizing those? Do they have the appropriate access to care that they need to do that? These are the things that we measure and focus on to really drive that overall performance improvement and overall goals, but also to make sure everybody has access to look at some resources, look at some information, understand where they are, where others might be, and how they're going to improve together. So when you think about that in relationship to leadership and governments, a couple of things that we've learned as a part of this. In my past experience, one of the greatest things from an administrative and organizational side or operational side we can do is listen to what everyone has to say. Everybody in the network needs a voice, and we need to understand where they're at and where they're coming from, and then develop solutions collaboratively together. Physicians need to be leading that governance. Physicians talking to physicians and working with one another have great improvements and really move the needle more than anything that I've seen. Helping them collectively make those decisions and look overall at what's going on, understanding that and being transparent with it, gives that overall organization and that network the ability to make those decisions, to pull in those resources, and to identify those overall needs.
Awesome. Thank you so much, Sean. And now I'm going to turn to Dr. Julka, because one of the most important things we can do, in addition to helping every practice, is to help manage what's happening outside of our network. And again, this is something that Signify does better than anyone in the country. So Dr. Julka, tell us how you do it.
Thank you. So in CINs and ACOs, the attribution of patients is built upon the primary care. And one of the very important aspects to influence the outcomes and performance is to have a view of what's happening out of the network in terms of the spend. So how do we identify and manage the out-of-network spend that's happening when it comes to the whole continuum of the patients? You know, engaging the primary care and the patient relationship, very important. Getting that opportunity of annual wellness visits to coach the patients as to keeping the primary care in the loop, communication, facilitation of transition management that's happening. How do primary care manage the specialty referrals, providing that relevant data insights? That's very important. Leverage the performance information that you have that Sean talked about to see how is the out-of-network spend happening. In some communities, you will have the option of specialty groups that are better performers, and yield better outcomes. But there are several communities which don't have the option. There is a cardiologist, there is a orthopedic, but how do you work collaborative with them? Bring everyone on the table, look at the network performance, look at the patient performance, come up with how you can care for patients together better. To move the needle, it's important to engage and empower the facilities, providers, and influencers. When you're looking at the post-acute, then it's very important finding who is the influencer. In some markets, it is the therapist, or it is the case management, discharge nurses, or even CFOs when they own, IRFs and stuff. How do we bring a right understanding to bring additional value? I think that's very important. The next slide. So it talks about how it can move the needle. We talked about the adequate risk capture. That's important. But post-acute zone is one of the highest spend zones in ACOs, and that alone, with patients staying more at home, reducing potential readmission, managing the social needs, especially 90 days after discharge, working with the SNFs as signified as, working with them, collaborating with them in managing length of stay reduction as optimal length can really, really bring translate into a lot of savings. I will go into deep on each section in the next 2 or 3 slides as to how we do and how you can do this. So one control setting you have many times is during hospitalization. It's very important to manage the discharge transition. Identifying through the data who are those high-risk patients who are at risk of readmission. You have limited resources. How do you dedicate that social needs and do the care redesigns, look at the chart reviews of all the readmissions that are coming, and have a quick learning and modify your transition management based on that. What do you ask yourself? Do you have a cadence to review the discharge transition process? Tracking longitudinally with respect to readmissions, mortality, hospice, and spend? Do your discharge streams truly recommend right next site of care that's least expensive and medically appropriate for the patients? Are they actually leveraging high-performing networks and sharing those SNF scorecards or performance cards with patients and families so they can make the informed decision? Show them readmissions, infection rates, patient experience, falls, what's available on Compare and other data that you have. Do you look at the completed follow-up appointments with PCPs and specialists that's happening after the discharge? Last but not the least, as I said, you identify the high-risk patients. You have limited resources. Make sure they don't fall through the cracks. Provide the additional support, with solid transition for this. Medications, DME, caregiver, transportation, communication with the post-acute facility, even if it's a weekend discharge. This is your 7-day readmission opportunity right here as you manage and track the hospital discharges. The next setting is the post-acute care setting. For your high performers, hit refresh annually on your preferred network based on the outcomes and spends that you get. Update your scorecards accordingly that you share with your patients and case managers to visit your inpatient network. See how much spillage is having out of network and create education for your discharge teams to show them the true impact of the loss of revenue and the value by discharging out of network. If you're in the community that doesn't have the luxury of choosing preferred network, again, as I mentioned, create a platform to bring local SNFs, home health together, share the data, and come up with collaborative ways with the primary care providers for better mutual care of the patients. And support them centrally or through outsourcing with wraparound services with real-time patient information. Provide them with risk transparency while they are taking care of patients, order sets, patient education tools, care goals, whatever is needed to uplift them from where they are through focused efforts. Short reviews can be very, very powerful. Offer CNEs, help customize workflows if you're an academic institute or you have the bandwidth. So quality and quantitative care journey details tracking really helps identify those things. The next slide is yet another way that shows how you can stay in the loop and manage the post-acute spend, and that is through telephonic outreach. You can do it up to 90 days, That really helps reduce the readmissions, arrange the transportation, help address barriers with your community partners. There's need, there is supply. There are a lot of nonprofit, cool initiatives happening with the local businesses and CDOs. Engage with them. People need help with medications, behavioral health. Teach your patients and the care coordinators when to call, whom to call when there is a concern to avoid the ED and rehospitalization, and the clear escalation pathways back to care management, back to primary care provider, and back to the specialty. Oftentimes, the frustration is that nobody knows whom to call or who is the patient under the care of in those 90 days, and a lot of things fall through the cracks.
Awesome, Dr. Julka. This is really, really helpful. And we have a question from the audience. Just when we've all struggled to really engage specialists in value-based care, and Incentivize has done this better than anyone. What are some of the effective compensation models you've seen work in changing behaviors for specialists towards value and risk-based arrangements?
So one, if specialists do not have any direct benefit through the ACO and in value-based programs, one is diverting the volume towards better performers. So we commit to them that we will steer some volume towards them. And secondly, we can also share some incentives that we get in a non-dollar ways. Supporting, having investment in the ASCs and other kind of supports that you can provide in a more creative way as the need of the community or those groups.
Yeah, well, and in addition with the waivers, you can actually pay them part of the shared savings, right? So what kind of percentages are you normally seeing people like in a bundled payment program? How much of the savings that you generate for the providers are being shared with the specialists?
I think there is a significant percent. I don't know if I can share because that varies with the market, but and also people have to be willing to share. It also depends how much revenue is brought to the primary TIMs and how significant of the portfolio the specialists manage.
Got it. So what you're saying is that the increased volume is more of an incentive than perhaps potential shared savings down the road.
Yeah. And we have proposed, to CMS in one of the blueprint letters, and a lot of public is also responding to that, to engage and come up with more value-based programs that are more inclusive of specialty practices, because they truly influence a lot of spend and outcomes in our complex patients, and as well include some post-acute facilities in certain way for shared savings together.
Right. Well, I'm looking forward to implementing those under the total cost of care programs too. Our last slide here just shows some of the results is the case study. Can you talk a little bit about the case study?
Yes, absolutely. So I'm going to end the success story of one of our clients who outsourced the post-acute care management to us in their very first year of MSSP program, and these are the results. So just with pure post-acute care management, when you provide some wraparound services where the provider's limitations begin, we could save discharges to SNF. There were 12% reduction. So people going to the lowest cost setting, like finding the post-acute opportunity, working with the post-acute networks locally, and helping the SNF perform better. There's length of stay optimization has savings, and very important bucket was reduction in the readmissions through regular call cadence, touching base with the post-acute facilities, and helping communication back to the hospital where the patient came from and to the primary care provider, reducing readmissions overall, learning quickly through chart reviews and network utilization data reviews.
That's great. You know, we had a question from one of the participants. Is like, how do you help these solo practices? You know, and there's a lot, and I feel like the community hospitals that are out there, you know, embracing those solo practices, bringing them into their CIN, you know, it's a huge challenge for them. And so some of the things you talked about here are supports that you can give to those providers, you know, kind of from a network perspective that really help everyone, which is great. And then, you know, from our side, from the Caravan side, we also train, you know, small practices on how to use staff to do a lot of the majority of the population health work, the wellness visits, chronic care management, and to bill incident to that supervising physician, which then really increases their primary care capacity by using licensed professionals to do a lot of the work of population health. So thank you very much for that, Dr. Julka. So my last section here, before we go to a couple of questions, is really about incentivizing, so kind of continuing on the theme of how to appropriately incentivize clinicians. And, you know, what I'd like to say first and foremost is make sure you pay the doctors. You know, honestly, this is, you know, all of our value-based programs, the patients are attributed to the doctors are doing the work, they're, you know, I mean, they, you know, we're just support team for our amazing physicians. So give as much to the doctors as you can afford to give them. You know, obviously you've got to cover your costs of the program. You've got to support the CIN and staff and things like that. But it's important to get as much dollars into their hands as possible. Remember that this is a payment model, and we are asking them to replace fee-for-service someday with these value-based payments. And the more payments we can get them, the better. So, you know, with some of that, there's also, you know, just a little bit of things to think about in terms of their shared savings. There's population health revenue. You can use these programs to increase your 340B revenue. And there's also MIPS and APM bonuses that come along with the program. So make sure, you know, in this scenario, we have a projected opportunity of about $630 per patient per year by making sure you're getting every dollar you can out of the program. And that means billing for a lot more prevention, wellness, and chronic care management. You couldn't bill enough for those services because every dollar you spend, you make two back. So I mean, every dollar you bill for will make two back in shared savings. So please, you know, invest in that type of work. You know, so reward excellence, group your peers so that their overall rewards for their peer group will reflect their advancement and their effort, and also gives them a reason to get better, right? And so if I know that, you know, in my basic program, I'm going to get 2%, you know, a couple $100, I might be happy with that. But if I'm looking at the guy next to me saying, wow, if I got those nurses doing prevention and chronic care management, I could be in the enhanced program, I could make $400 a patient. Well, that becomes significant. So it also creates a ladder for success. And you know, you got to honor everybody where they are as long as they're willing to do the basic work of wellness, prevention, and chronic care management. They should be able to stay in your program, but they are probably going to stay in that very basic rate. Make sure you only pay for what you can measure, so attribution, rates of effort, rates of services that provide value, attendance, utilization of face sheets tells you how well they're doing on reviewing missing codes. So there's lots of things you can count. Pay for what you can count. Don't pay them based on cost and quality, which is really not the best way. The physicians that have the lowest quality tend to have the most difficult patients. Don't punish them for that. And then manage expectations. Make sure that future results are not guaranteed by prior performance. We always have to continue to get better. And so I'm going to go from here and just quick conclusions, because we have some questions and I want to see if I can answer them. Every community's got a mix of practices that have varying results. They can be grouped with their similar peers to maximize the rewards for the program and keep your network together and protect your network from cherry pickers that are going to come off and pick out your high performers. And that reduces envy and provides a clear path to the future. Create programs that incentivize your high performers, provide the right tools, and invest where the practices struggle. Manage the out-of-network care, manage post-acute, provide chronic care management services for your small practices. That's a hard service for them to implement. So there's things you can do that will really make a difference for everybody. And now I'm just going to see if I can spend a couple of minutes going through some questions. Yes, we will send you the slides. What is the overhead to support CIN needs from an FTE perspective per 1,000 lives? That's very, very specific. We hear it costs too much to set up and maintain a CIN. Well, it's really interesting because you can you meet all of the qualifications for a clinically integrated network by entering the Medicare Shared Savings Program. I call it a poor man's CIN because then you've got data, you've got contracts, you've got shared savings arrangements, you have a board, you have an entity, you've got committees. You can do this for very, very little money. We've been doing it over and over again. Or you could work with somebody like Caravan who'll just do it for you, and we won't charge you anything until you get shared savings. So anybody can do this, and it's really a benefit to your community. Let's see. I think we are out of time, and I do appreciate everyone's time today. Thank you so much for coming, and I do thank my speakers, Sean and Dr. Julka. You guys were fantastic, and thank you, Beckers, for giving us this opportunity to share what we've learned at Caravan over the last 10 years. Thank you very much.